Hello everyone, welcome back to Aquino Health. Today we are discussing a recent Nature publication by Professor Ravi Litnaka on the metabolic effects of adding exenatide to basal insulin therapy when targeting remission in early type 2 diabetes in a randomized clinical trial. Combination therapy consisting of a GLP-1 receptor agonist and basal insulin has emerged as an effective therapeutic option in the management of long-standing type 2 diabetes. These enticing features have led to the suggestion that combined treatment with basal insulin and GLP-1 receptor agonist warrants consideration when first initiating injectable therapy in patients with long-standing type 2 diabetes and suboptimal glycemic control on oral medications. Moreover, these data raise the intriguing question of whether initiating this combination therapy early in the course of type 2 diabetes may offer enhanced metabolic benefits. When administered in early type 2 diabetes, a short course of insulin therapy for 2 to 4 weeks can improve beta cell dysfunction and even induce glycemic remission. While these outcomes have most commonly been achieved with intensive insulin therapy or either multiple daily injections or continuous subcutaneous insulin infusion, basal insulin alone can also yield such benefits. Moreover, the outcome reduction with an initial glargine intervention or Origin trial found that in patients with prediabetes, treatment with insulin glargine significantly reduced the risk of developing type 2 diabetes, with partial protection still evident about 3 months after stopping the treatment. However, in practice, the implementation of early insulin therapy can be limited by the patient and provider's fear of the risks of hypoglycemia and weight gain. Furthermore, the degree of beta cell functional recovery in response to this intervention can be heterogeneous, and the induced remission of diabetes is not permanent, ultimately waning over time. In this context, authors hypothesized that combining basal insulin with a GLP-1 receptor agonist in early type 2 diabetes may provide a strategy that could enhance the achievability of the desired metabolic outcomes or improved beta cell function and diabetes remission while limiting the risks of hypoglycemia and weight gain. Since it is believed that short-acting GLP-1 receptor agonists act preferentially on postprandial glycemia through their inhibitory effect on gastric emptying, or in contrast to long-acting formulations that have more pronounced effects on fasting and post-absorptive glycemia, the main reason is that combining the short-acting GLP-1 receptor agonists exenatide with basal insulin may provide optimal complementarity in metabolic coverage. Indeed, recognizing that the postprandial glucose-lowering effect of exenatide correlates with the magnitude of its inhibitory effect on the rate of gastric emptying, this short-acting GLP-1 receptor agonist should reduce the insulin secretory demands placed on the beta cells, thereby inducing a degree of beta cell rest. In this clinical trial, authors sought to determine whether adding exenatide to basal insulin therapy in early type 2 diabetes can enhance the achievability of beta cell functional recovery and diabetes remission as compared to basal therapy and basal insulin alone. Finally, authors demonstrate that the addition of exenatide to basal insulin does not further enhance underlying beta cell function or the capacity to achieve diabetes remission in early type 2 diabetes, but does yield on treatment glycemic and weight benefits. The preserving beta cell function in type 2 diabetes with exenatide and insulin trial was an open-label, parallel-arm, randomized controlled trial that was designed to evaluate the metabolic effects of 3 insulin-based therapies such as glargine alone, glargine plus lispro, and glargine plus exenatide early in the course of type 2 diabetes. In this 20-week trial, as shown in the figure, participants were randomized to 1-to-1 of these interventions for 8 weeks, followed by a subsequent 12-week washout of any anti-diabetic medication. As you can see in the figure, participants underwent assessment of beta cell function, insulin sensitivity, and glucose homeostasis by oral glucose tolerance test, ROGTT, at baseline, 4 weeks, 8 weeks, and 20 weeks, that is after 12-week washout. As shown in the figure, the total participants recruited 105, but a couple of participants withdrew from the study or were ineligible to continue in the trial. So the analyzed study population consisted of 102 participants with type 2 diabetes of median 3.5 years duration, baseline A1C 6.6%, and BMI 31.9 kilograms per meter square. These participants were randomized to one of 3 interventions: insulin glargine alone, glargine plus preprandial lispro, or glargine plus twice daily exenatide. The baseline characteristics of the groups showed no significant differences in clinical or metabolic measures as shown in the table. The initial daily dose of glargine was similar across the three groups. 6 participants withdrew during the trial, 1 from glar, 2 from glar plus lispro, and 3 from glar plus exenatide. Of note, all three interventions induced a significant reduction in A1C at 8 weeks. However, there were early washout visits in 19 participants, 7 from glar, 7 from glar plus lispro, and 5 from glar plus exenatide. The primary, secondary, and additional outcomes are shown in table. The primary outcome of mean ISSI2 over the 8-week intervention did not differ across the groups. The secondary outcome of baseline adjusted A1C at 8 weeks was lowest in glar plus exenatide, followed by glar plus lispro and glar alone. Additional outcomes at 8 weeks revealed that baseline adjusted weight and BMI were lowest in glar plus exenatide, coupled with lower baseline adjusted 2-hour blood glucose and the OGTT. There were otherwise no significant differences between the groups in 3 additional measures of baseline adjusted beta cell function at 8 weeks, or in baseline adjusted insulin sensitivity. Since all participants were negative for anti-glutamic acid decarboxylase antibodies except for one individual, in which the assay was indeterminate, the authors ran sensitivity analyses in which the latter individual was excluded and confirmed that the findings for all outcomes were unchanged. After a 12-week washout, the additional secondary outcomes of baseline adjusted ISSI2 at 20 weeks and baseline adjusted A1C at 20 weeks showed no significant differences between the groups. There were also no significant differences in the additional baseline adjusted measures of beta cell function, insulin sensitivity, or resistance, glycemia, or anthropometry. Thus, the beneficial effects of glar plus exenatide and glycemic control and weight that were observed after 8 weeks of treatment did not persist in the 3 months that followed after stopping the therapy. The figure shows the changes in metabolic measures in the 3 groups over the 8-week intervention and subsequent 12-week washout. As shown in Figure A, A1C changed differentially between the 3 groups during the intervention, or time treatment interaction p-value of 0.03, with a greater decrease in the glar plus exenatide and glar plus lispro arms than in the glar group alone. As Figure B shows, during the washout, however, A1C returned to a similar level in all 3 groups. With fasting glucose, each therapy yielded a similar pattern of reduction during the intervention, followed by rising levels during the washout. Figure C shows all 3 therapies induced an increase in ISSI2 by 8 weeks, but this improvement in beta cell function was lost during the washout, thereby mirroring the pattern of changes in A1C. Figure D shows the changes in insulin sensitivity, or Matsuda index, were more variable but did not differ between the groups. In contrast, the interventions induced a clear differential effect on BMI, which was lowered only by glar plus exenatide or time treatment interaction, as shown in Figure A. A similar differential effect with p-value equals 0.05 was seen in the reduction of waist circumference by glar plus exenatide in Figure B. The additional categorical outcomes assessing glycemic control yielded further insight into the relative effects of the interventions both on therapy and after 3 months washout. Of note, the groups differed in the prevalence of 1C lesser than or equal to 6% at baseline, with this degree of glycemic control achieved on pre-study medications in 43% of the participants randomized to glar plus lispro, 24% of those assigned to glar, and 15% of those in glar plus exenatide, as shown in Figure A. After 8 weeks of their randomly allocated interventions, these proportions increased in all 3 groups but to different degrees, with the highest prevalence of 1C lesser than or equal to 6.0% now observed in glar plus exenatide 73%, followed by glar plus lispro 66% and glar 39%. These differential effects of the interventions were then completely lost at washout. Finally, the prevalence of remission of diabetes after a 3 months washout did not differ significantly between these 3 insulin-based interventions. There were more individuals in the glar plus lispro group with at least 1 episode of capillary glucose lesser than 4.0 ml per liter than in the glar plus exenatide or glar groups, with no such differences at more stringent hypoglycemic thresholds of lesser than 3.5 ml per liter as shown in the table. There were no differences between the groups in the number of hypoglycemic events or the rate of events per patient year, any of the glycemic thresholds. In conclusion, the addition of exenatide to basal insulin glargine in patients with type 2 diabetes of modest duration did not further enhance underlying beta cell function beyond the improvement achieved with glargine alone. Nevertheless, at this early point in the natural history of diabetes, glar plus exenatide outperformed glar plus lispro and glar in yielding greater reduction in weight and A1C, with 73.3% of patients achieving A1C lesser than or equal to 6.0% at 8 weeks. However, none of these benefits persisted over 12 weeks washout, such that the prevalence of diabetes remission ultimately did not differ between the three insulin-based interventions. Thus, these data do not support the addition of exenatide to short-term basal insulin therapy as a strategy for enhancing the achievability of beta cell functional recovery and glycemic remission in early type 2 diabetes.